So we took a look at blood flowing through the heart, and then we talked about how it originated was because of the electrical conduction system. So now we're going to put this together and just map it out so it makes sense together. So here's our graphical representation of when we have our cardiac cycle. Okay, so the cardiac cycle is basically from the beginning of one heartbeat to the beginning of the next heartbeat. So here, our atria and our ventricles are both at rest. During this isoelectric line, this baseline that we have with our EKG, no blood is pumping right now. Everything is just at rest. There's nothing contracting. We then initiate this cardiac cycle with the SA node firing. It's that pacemaker for the car. And it is going to contract all the rest of the contractile system. And the atria are going to contract as well. They're going to depolarize and contract. So here is where we have atrial systole, because remember, systole means the heart is contracting, and we just depolarized all the atrial heart cells, the myocytes. So we have atrial systole occurring, but the ventricles are still at rest, right? So we are actually contracting the atria first. Then we depolarize all of the ventricular myocyte cells. And in response to that, we have everything contracting in the ventricles. So now the ventricles are currently contracting while the atria are resting, right? So we have to pump on the atria first, then the ventricles. So that's where we hear if you've ever heard of lung sounds, you hear love dub, love dub, love dub. You hear that double beat because first it's the atria, then it's the ventricles, right? And it's all being led by these electrical impulses that we can visually see within the EKG representation. And when we put it all together until we lead into the next depolarization of the electrical conduction system in the atria, it's called one cardiac cycle. So it's the beginning of one heartbeat to the beginning of the next heartbeat. When we're taking a look now of how can we tell what's going on with the EKG and what are the rhythms that we can look at to be able to find out if this person is healthy or not, we can go through a process in which we can analyze them. So we're looking at basic rhythm identification. How do we identify what the EKG rhythm is showing us and what it tells us about the heart? So it's a systemic process. The first thing we're going to do when we look at any kind of a rhythm strip is we eliminate the garbage. There's often garbage that comes with it. I'll show you some examples and we'll talk about later what that garbage might be. Then we're going to, instead of looking at everything, we're going to just identify what the underlying rhythm is. And we're going to find out if it's regular or irregular rhythm. So is it a regular rhythm or is it not? We're going to take a look at the rate to figure out how fast it is, because that's going to tell us what kind of a rhythm it is. We're going to look and identify what that underlying rhythm is, and then we can throw the garbage back in there to be able to figure out what else might be happening in the heart besides what's happening under the underlying rhythm. So first step we do is we eliminate the garbage. So we're going to pretend as if there's no weird things or no problems with the strip that we're looking at, and we'll come back and look at that later. So here is what we're seeing. And this is what we were looking at, it looks exactly like what we were looking at a little bit ago, where we have this P wave, a QRS, and a T wave, and then another P wave, QRS, and a T wave. And you can see that this is all steady going through here, but you'll notice that there's some weird stuff all of a sudden that's thrown in here. This is what we're going to consider the garbage. So we're going to throw it out. My husband likes to refer to it as cutting out the crap. It's like, this is just weird. We're going to deal with that later. And instead, just be taking a look at what is this rhythm that's happening underneath here when we get rid of this garbage that we can see. So what we want to do is we want to identify if it's a regular rhythm, which means that it's constant and steady, and the R to R intervals are the same between each of these different cardiac cycles. So the distance from this R interval to R interval is the same as from this R interval to this R interval, which is also the same from this one to this one. If all of a sudden we would see these either closer together or further apart, we would call that irregular, that it's not a regular rhythm. However, in these ones demonstrating it, it is regular. We called it marching out. It's like it's appearing at the same time that I could even predict when the next one's going to come based on what the ones before it were. Okay, then we want to take a look at the rate. And there's a lot of different ways that we can actually look at the rate, and there's technical ways for us to be able to do that. But for our level of purpose, I just want you to understand that often you can just go with what the interpretation is at the top of the EKG. So printed up here, it would have like an ID number. And then here it's giving you heart rate. And this one actually happens to have like an oxygen saturation also listed on it. But you can look at it and say it's 60 beats per minute. So that's our rate. Now, if we go back and we take a look at what these different rates are, so we're trying to figure out, is this fast or is this slow compared to what a normal heart rate would be? Well, anything that is below 60 beats per minute would be considered bradycardia. Cardia means heart, brady means slow. So bradycardia would be a slow heart rate. Anything that is above 100 beats per minute is a fast heartbeat. Tachy means fast. So tachycardia is a fast heartbeat, indicating that it's above 100 beats per minute. Anything that is between 60 and 100 is just considered a normal rate. That is where we normally see people based on what their health status is and what activities they're doing. Typically, we will see it somewhere between 60 to 100 beats per minute. Once we go beyond those extremes, we start to become too fast or too slow, and we call that bradycardia and tachycardia. So we want to check to find out if our heart rhythms are starting where they're supposed to start, which is that sinoatrial node. So these are ones that would be considered sinus rhythms. Sinus means it's starting from the sinoatrial node, the SA node. How do we know if that's happening? Well, a normal sinus rhythm, normal is going to give us our speed, right? So the rate was between 60 to 100 beats per minute. When we look at it, it was regular. So these are the characteristics of a normal sinus rhythm, that it's completely regular, and these R to R intervals are predictable from the space between one to the next. We can see P waves. So when we see P waves right here, we know that it is coming from the SA node. We can see that it is coming from the sinoatrial node, which means it's a sinus rhythm. For every P wave, we have one QRS. So this is looking at the P to QRS ratio, which means for every time the atria fire, the ventricles are going to fire, and then it's going to happen again, right? This P to R interval, so the distance between this P, the beginning of the P wave and the beginning of the R wave, is a normal amount. It's not too elongated out with a pause in between. And when we look at the QRS complex, it's narrow in scope. And right now what we can see is this is a narrow one because it is less than 4 of these tiny boxes added up together. Once it goes beyond 4 tiny boxes together, you'll see it being more elongated, and it creates what's called a wide QRS. And we'll see a picture of that in a little bit. But for now, we're taking a look at a normal sinus rhythm. We know it's sinus because it has a P wave before each of the QRS complexes. And it's normal in that the rate is between between 60 to 100 beats per minute. Now, when we look, this one's called a sinus arrhythmia. So the first thing we do, we can look at the rate and we can see, and we got a report based off of the, what would have been written here at the top of the rate. I can actually calculate it. Give me a second. So this is 300, 100. 50, 150, 75. It's probably like around 72 beats per minute. I know that simply because of the distance and how many boxes are between one QRS complex to the next QRS complex, because that's another way that you can calculate it. Normally, it would be written at the top though. So this is actually around like a 72, maybe 70 beats per minute. But when you look at it and you're looking to find out if it's regular, you'll notice that from here to here, it seems pretty steady, but here it gets a little bit longer. I can't quite tell, but do you see how that this distance is longer than this distance here? This is showing it's an arrhythmia, meaning that it's irregular rhythm. It's not a regular rhythm because there's this alteration. Now, when I look at this, I know that since it's a sinus rhythm and it is a normal rate, but I see a little bit of this arrhythmia, this is actually happening from breathing. So this is what a lot of ours will look like. And especially the more in shape you are, the more likely it is that your heart rate changes based on your breathing. So what we're seeing here is that when we're inspiring right here, our heart rate speeds up a little bit. When we expire our air, it slows down just a little bit. And so that's what we're seeing with this arrhythmia, but it's an arrhythmia in the sense that it was not a regular rhythm. It has a little bit of variance with it, and that's coming because of the respiration. Now, when we look at this one, the rate here would be 300, 150, 100, 75, 60. That would be 50. So we're right around like 54 beats per minute. So this would be 54 beats per minute. Please keep in mind, you don't need to know how to calculate that out. I'm just letting you know what the rate would be. It would be around, um, it would be around um, 50 beats per minute. When we look at the regularity, we'll notice that the R to R intervals are the same as we go across. So we know it's a sinus rhythm because it's starting with a P wave before each of the QRSs. We knew our rate was lower than 60 beats per minute, but it is regular. So this would be sinus bradycardia. So it's starting from the sinus, from the SA node, and it's a slow heartbeat because it's below that 60 beats per minute. On the opposite side of things, what if we are looking at a fast heartbeat? So here, this one we're looking at would probably be around 140 beats per minute. It is regular in that you can see the R to R intervals are marching out, or what, that's the same distance between each R to R interval as we go throughout the strip. We do know it's coming from the sinus, from the SA node, because we can see those P waves before each of the QRS complexes. And so this would be sinus tachycardia. It's coming from the sinus, from the SA node, and that it is a fast heart rate because it'd be around 140 beats per minute. Okay, so those are the ones that are coming from the SA node, but there's other places that beats can originate from. Essentially, we build up bad habits. We eat too much fat and sugar, and we don't exercise enough, and we put too much strain on the heart itself. And over time, these bad habits can actually start to lead so that some of the cells in our heart are damaged. And one of the more fragile set of cells that we have is the SA node. So the SA node, the sinoatrial node, is very fragile. It's highly excitable, so it fires first. But when we start to have damage, it might not be firing at all. So these are rhythms in which we're taking a look that it is starting from the atria, but it's not specifically starting from the SA node. It's just the atria are firing. So what happens with atrial fibrillation? So fibrillation means to quiver. And this quivering is coming from the atria itself. So imagine for a moment, the heart is waiting for a P wave. It's waiting for the SA node to fire. Well, it's not seeing it fire, but we have like understudies that are wanting to step up to the plate. And they're like, okay, well, if the SA node isn't going to fire, we're going to go ahead and make sure that the heart is still going to beat. And how do we do that? We have a bunch of atrial cells. So cells that are in the atria, in those internodal pathways that we looked before, that will start to fire. And it's kind of like all of the different understudies are like, oh, no, wait, I'll go, right? So every time you have these different ones, they're like, oh, I'll go. And they're all trying to fire. But what happens is when it hits that AV node or the AV junction, it only allows for one electrical impulse to go through to get to the ventricles. So think of it like a train junction in which you have train tracks that are coming together from two different tracks to form into one. And what happens is that it allows for only one train to go through at a time. So it'll kind of direct or slow down or move other ones or stop trains to make it so that only one train can go through at a time, which is why it's called a junction. So if I have multiple different firings that are happening in the atria and they're all like trying to fire, the AV junction or the AV node makes it so only one impulse can travel through to the ventricles, which then makes the QRS complex fire with the ventricular depolarization. What happens when this is occurring is that all of these different firing produces an effect in that it's not sure which one's going to go through. So they go through at different times, which means our regularity is irregular. It is not as regular as what it would be with our sinus rhythms. So you see a long R to R interval right here, but here's a shorter one. Here's kind of an in-between one. It's kind of random as it's going through because it just depends on which impulse is going to go through the AV node to be able to depolarize those ventricular cells. So that's called atrial fibrillation. Fibrillation means to quiver. So it essentially means that the atria are kind of quivering as it's trying to contract all these different cells from all around. It kind of looks like what would be considered like a bag of worms, and they're all just kind of like squirming around. That's visually what it looks like in the heart when you have all these electrical impulses that are trying to fire. But it only allows for one to go through, so you have coordinated firing of the ventricles themselves. So what causes atrial fibrillation? Well, it can be caused by underlying heart disease, coronary artery disease. So maybe it's not within the heart itself, but it's the arteries that are feeding the heart. And actually just having high blood pressure can also lead towards atrial fibrillation. So then the question is, there's a lot of people out there who are often in chronic atrial fibrillation. So the question is, how bad is that? Well, when you look at it, nobody here, right, in these athletes is probably an AFib right now, atrial fibrillation. However, some of these guys could be. So the question becomes like, how dangerous is it? Well, it can lead to issues. One of the bigger issues that we see is that with the heart quivering within the atria, it stagnates blood for just a little bit of a time and it creates a little turbulence there. When that happens, blood starts to coagulate together. So now we could be forming clots within the heart that are going to get pumped out to different places. One of the places it goes first can be up to the brain itself. So people who are living in atrial fibrillation are more prone to having a stroke because of a blood clot that could be lodging. Because in that atrial fibrillation, we have that coagulation of the blood occurring. It could also be going to the lungs, right? Because that's the other place it can go, in which in the lungs, they would have a pulmonary embolism, in which they actually have a blood clot that's forming in the lung, stopping blood flow and the exchange of gases there. So the blood pools in the atria causing these clots, leading to a possible stroke. Also, because the chaotic electrical activity we have, the atrial aren't really coordinating their contraction, which means it's kind of happenstance. But we still need to get blood from the atria into the ventricles. The good thing is this is still happening because remember, 80% of the blood flow that's coming from the atria to the ventricles is through passive gravity falling, right? It's passive filling where the valve just opens up and blood dumps from the atria into the ventricles. What's not getting pumped out is that 20%, since we don't have that coordinated effort of the atria contraction. And that's why that blood is starting to coagulate there and cause that turbulence in that area. So that was one that we could see that was coming from the atria. Now, those were great understudies because they wanted to make sure that the heart was still beating, and it did allow for one impulse to go through so that we had a coordinated contraction of the ventricles. However, if the atria are all offline and those cells aren't working, the ventricles still want to beat because it knows that that's the only way for us to survive and get blood up to our brain and to the rest of the body. So, what can happen is our ventricles will start to fire, and they are clumsy at firing. So, what happens is all the ventricles, the myocytes, can start to fire. So, there's a lot of them firing. But instead of having that AV node in order to coordinate it, or that AV junction to only allow one impulse to go through, now it's actually allowing for all of those ventricular beats to go through, which means there's a lot of them that could be happening. So this is going to be a fast heartbeat, tachycardia, originating from the ventricles. So the rate will be somewhere between 100 to 200 beats per minute. This one right here is right around like a 130, 140, I would say, beats per minute. And it is regular in that it is continually beating over and over and over again in a regular rhythm. However, we don't see a P wave. We don't see the coordinated effort between the atria and the ventricles at all. And when you look at the width of the QRS complex, so here was like QRS, it's really wide. This is our wide complexes. So this is letting us know it's coming from the ventricles itself. When we start taking a look at the actual contraction of the contractile cells, we'll explain why this is happening and why it takes so long that it actually is this wide QRX. But they kind of look bizarre, right? Some people talk about that they look like tombstones, which means that they're very quickly leading towards death. So when we have ventricular tachycardia, this is not a healthy rhythm at all. They are on their way towards cardiac arrest. Now, for a moment, I want you to visualize family gatherings at your house. Right. And one of the fun parts, the only fun part about the family gatherings when it came to cleanup was when you would wash the turkey baster. So if you guys remember what a turkey baster is, it could be any kind of a baster, but it's often called a turkey baster. You have a bulb on the end of a tube, and it acts as a bulb syringe in which if you put it underwater, the end of the tube underwater, and you squeeze the bulb, you'll have all the air exit out, and under the water, you'll be like blah, 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 and you'll have the bubbles that are coming out. Now, if you keep that tube under the water and you let go and release that bulb, it's going to suck the fluid up into the bulb, right? And we use this to baste the turkeys or the hams or whatever meat it is that you're doing so that you can put it in all the juices, suck up that fluid, and then squirt it onto the meat itself to keep it juicy, right? So as a kid, remember you would play with this probably when you were doing dishes, and you would put it under the water and you would squeeze it out and you would have the flow going out, right? And then you would release it and the fluid was sucked back in, and then you would squeeze it out and it would pump it back out again out of the tube. And you can kind of see this as a cycle and equate it to the heart, right? Where you're squeezing it, the heart contracts, it beats the blood out, you relax it, it fills it back up again, you squeeze it. Now, granted, it doesn't come in and out the same hole in the heart as it does with the turkey baster. It's instead coming from the top and traveling towards the bottom. But I think you can get the analogy of what we're seeing right here, right? So you continue doing this, right? And you do have a heartbeat each time. You do have fluid moving each time you contract this bubble. But as you start to speed up the contraction and it becomes faster and faster and faster, it can get to the point in which I wish you could see my hands because I'm contracting my hands right now. But you can actually get to the point in which you are contracting and pushing so fast that it doesn't allow for enough time for the bulb syringe to fill up with fluid before you're already squeezing it again. And everything just kind of stays stagnant because you're going so fast. So this is the same within the heart. So sometimes with ventricular tachycardia, you can actually have a heartbeat, but sometimes it gets so fast that it actually doesn't allow enough time for blood to fill back in the heart again before it's actually trying to pump the heart, the blood back out again. And it can actually have no pulse that is happening because of it. So you can move from having a pulse to not having a pulse. And that's why it's important to look for these signs of circulation to find out if the blood is actually pumping around the body. If it's not, this is when we would begin CPR, right? So we would begin CPR because we do not see signs of coordinated effort in that they are not breathing, they are not coughing, they are not moving, and they do not have a heartbeat, and we would begin CPR. Now what I want you to imagine is that your brother or your sister walks in as you are cleaning this turkey baster and you pull it out and everything is swarming all over the kitchen and you are just spraying everything everywhere and it's all chaotic because now the fight has begun of the turkey baster and spraying those around you. So oh, sorry, back up just a moment. With our ventricular tachycardia, so what causes this? Not having enough oxygen getting into the heart muscles themselves because of a lack of blood flow. It can also because we have an extreme outpouring of sympathetic activity. So if our sympathetic nervous system is acting, is overacting, we can have ventricular tachycardia happen. Hypoxia is not enough oxygen within the system itself, and then sometimes just having electrolyte disturbances. So remember, all muscle contraction is happening because of ion flow. If those ions are off kilter and aren't ratioed appropriately, we can start to have these disturbances as well with ventricular tachycardia, also known as VTAC. So let's go back. And our brother walks in and we are spraying this turkey baster all over the place and everything is chaotic. That is what our ventricular fibrillation is. It is complete chaos of electrical rhythm. Everything's firing all over the heart and nothing is happening in coordination whatsoever. So you can't determine a rate because we don't even know what's happening right here. There is no blood actually pumping through the heart at this time because nothing's in a coordinated effort. Everything is just in chaos. So this is ventricular fibrillation. Remember, fibrillation means to quiver. Ventricular is that it's coming from the ventricles themselves. So just imagine we've got like a sack full of worms and everything is just firing all over the place and you can see all this electrical impulse on there. The heart is not beating, blood is not pumping around. They are in cardiac arrest. They are clinically dead at this point and we would be doing CPR. What causes this? A heart attack can cause this. Having a low level of oxygen, having those electrolyte the electrolyte disturbances that we have, being shocked of some sort, like getting an electrical shock or like lightning shocks or something like that can happen. And then also some drugs can actually do this. Digitalis is a pretty strong drug that can do this. That's why it's often prescribed to elderly, and we have to make sure that it's very well protected around kids, because one pill can actually send them into ventricular fibrillation, or ones that are mimicking the sympathetic system. So any drug that is mimicking a sympathomimetic, mimics the sympathetic system, could be causing ventricular fibrillation as well. The last rhythm we have is called asystole. Now remember, systole means to be contracting, for the heart to be working. A means it's not. So this is no electrical activity in the heart whatsoever. This is what we know also as our flatline. Flatline, no electrical activity. So what's interesting, and I just want to do this as a side note, when we go back and we look at ventricular tachycardia, this might be perfusing, meaning it might be pumping blood, therefore bringing oxygen to different places and around in the body. If it's not, and it is pulseless, so it doesn't have a pulse associated with it, they are very quickly going to be going into ventricular fibrillation. Here is where we have quivering of the heart. This is not producing a pulse at all, but we have this chaotic electrical rhythm. So when we look at this, one of the biggest things we need right here is we need to stop this electrical chaoticness in hopes that it will restart on its own. Think about back to the 1900s, and you had the hysterical woman, right? You have the hysterical woman who was acting out, and they were throwing a fit, or whatever you want to call it. This is a gross stereotype and generalization, but I think you can understand the analogy with it, in which then the only way that people would treat it was by slapping her, right? So they would slap her across the face to get her to like sit for a moment and calm down, in hopes that her demeanor would turn back to being normal again, right? So when something catastrophic happened in her life, like a child had died and she's, completely catastrophic, everything is happening and is freaking out, essentially, you would go and slap her in hopes it would stun her in order for everything to return back to normal again. Well, what we do with ventricular fibrillation is a cryptic form of that, in that we slap the heart with a jolt of electricity. It's called an automated external defibrillator. Automated because it actually does it on its own. It can read the heart rhythm and know what's happening, and will know whether shocking it or delivering this massive amount of electricity will help it or not. So it's automated. External because it's outside of the body, and a defibrillator, right? Fibrillation is to quiver. We are going to stop the quivering. So it delivers a jolt of electricity in hopes that it will stop the chaoticness and start again with a normal rhythm, right? So that's what an AED does, an automated external defibrillator. Well, here is our flatline. Flatline means no electrical activity. Well, with no electrical activity, there's nothing that we can stop, right? We can't stop no electrical activity, which means in all the movies and the TV shows that you see where somebody is flatlined, right? Baywatch, there's a whole movie, Flatliners, about it, right? With Kiefer Sutherland, although I think there's a remake as well. When we are at a flatline, there's no electrical activity. We will not shock this. We will not use a defibrillator because it can't stop no electrical activity. So this is the number one falsity of media when it comes to the medical field, is that we often will portray it as if we would shock asystole or this flatline. And in fact, we do not do that. I wish that movies would no longer show that, because when me as a medic can show up on scene and we see this no electrical activity, I can't do anything. I can't shock it. And people don't understand that because it's such a misnomer out there because of just in education. So just keeping this in mind, this is no electrical activity. The only thing that can happen right here is we can try to give drugs that will help to stimulate some activity within it. So it's not through shocking, it's actually through administering of medications like epinephrine. If you guys have ever seen, what's the movie? Pulp Fiction. Pulp Fiction, in which they take the big needle and they hammer it into Uma Thurman's chest, right? To be able, or no, she's the one who does it. I haven't seen Pulp Fiction in a very long time, but they use the big needle to be able to put it in. It's epinephrine, which is like adrenaline going into the body to help stimulate something happening within the contractile cells through drugs, not through shocking. Okay, so let's come back, because what we did is we were looking at the rhythms. We got rid of the garbage, remember? So let's put the garbage back in now. So we decided what that underlying rhythm is. Let's talk about when these abnormalities come up and what are these abnormal beats. Sometimes it's just artifact, which means they're false waves because there are some other bioelectrical impulses happening. Mainly they're moving, right? So we might just have like regular rhythms, everything's looking good, and then all of a sudden they cough, or they move their arms or legs, or they sneeze, or they begin talking even. All of that can just give what's called artifact, which are these bumps up and down that are not part of the normal rhythm. It's just like a bioelectrical feedback that's happening. So sometimes some of that garbage is just artifact itself. Sometimes it's premature complexes. So it's basically a complex that's coming before it was scheduled to come, right? So here we were having everything to fire, everything was normal, we're marching along, everything is good. And then all of a sudden, for some reason, somewhere in the electrical conduction system, it decides to fire a little bit earlier than what it was normally supposed to fire in. It could be coming from the SA node, it could be coming from the atrias, it could come from the AV node or the AV junction or the ventricles. So it could be coming from anywhere, but it fires and it's like, oh, wait, so I just fired. And then all of a sudden it kind of like does this shake of the head and like, okay, let's just go back to being normal again, right? So that's some of the garbage that could be happening, is that could just be coming before it was normally scheduled to happen. Here's an example of that coming from the ventricles. So here was a normal sinus rhythm happening here, but then all of a sudden, like clunk, clunk, and the ventricle decided to fire for whatever reason. It just all of a sudden was sensitive enough that it actually fired the ventricles. I know it's the ventricles because of how wide this QRS complex is. That's how I knew it was from the ventricles, because that's what happens when things are coming from the ventricles themselves. Then it does like a little pause, right? So you can see that right at the tip of the arrow. We get this pause, and then it just goes back to being normal again. This is called a premature ventricular contraction. So it's premature in that it was coming scheduled before it was actually scheduled to fire. It's a contraction. It results in a contraction, and it was coming from the ventricles. It's also known as a PVC. So the rate, it depends on whatever that underlying rhythm was. With here, it was a normal sinus rhythm. So it was a normal between 60 to 100 beats per minute, but all of a sudden there's this irregularity in it because of that. It doesn't have a P wave on it. So we know it wasn't a sinus, premature sinus contraction or an atrial contraction. It was from the ventricles themselves, and it has that wide QRS, which gives it kind of that bizarre appearance that you can see right there. So why do people have these? You might, I'm willing to bet that many of you have experienced this in your life and may not even have felt it. Sometimes you can actually feel them, in which all of a sudden you feel like a double beat in your heart, all of a sudden like a bump bump. And it's not just like the normal beat. It's like all of a sudden it just like, you can just feel that it's like thud in the chest. That's often a premature ventricular contraction, or what's called a PVC. So what are the different reasons why it could be coming? Well, it can indicate things like having a lack of blood flow because of and leading to a lack of oxygen within the system. It can be because you're nervous or stressed and have an increase in your sympathetic activity that's happening. It can be because of a lack of oxygen or some electrolyte disturbances because of the ions aren't flowing appropriately. But a lot of times, if you're the one who's feeling this in the healthy population, it also is a response to caffeine because caffeine impacts the contractibility and excitability of the myocytes as well. So that's usually what it's coming on with most people, is that it's a response to either stress or activity, or it could be because of caffeine. So those are our different rhythm strips that we have. We're going to come back on our next episode and talk about contraction of the heart muscles themselves.